This week we will focus our study on the impact of health literacy and creation of health education as a method of encouraging self-care in the management of chronic illness. The 5P assessment identifies common DRGs for each microsystem, and the CNL can use this information to improve the transition of care and patient-family self-care to reduce readmissions and cost while improving quality of life. The focus of healthcare changes from preventative interventions in the presence of acute or chronic illness and as patients need increasing support to develop resiliency and improve their ability to self-manage their chronic disease. Remember that many patients with chronic illnesses may also suffer an acute illness, whether related to or different from their chronic illness. Palliative care is often misunderstood, and it is important to educate the patient and family on the importance of creating an atmosphere of dignity and comfort as disease progresses. The impact of chronic illness can be quantified by epidemiological analysis of life and death rates, understanding the impact of illness on personal lives of both patient and their healthcare providers. As healthcare costs continue to escalate, appropriate resource utilization becomes an essential part of the care planning process. Overarching goals of chronic care management include the reduction of morbidity and mortality, minimizing the impact of short-term flare-ups of the illness, and optimizing the patient's quality of life. The clinical microsystems outcomes are directly related to the healthcare system's organization, the timely and efficient implementation of evidence-based care that is focused upon involving the patient and family and healthcare team in a collaborative manner that uses both the organization and community resources to deliver care. Improving Chronic Care website offers us more information on how to deliver quality care. Important to microsystem success is how the healthcare system has identified and implemented the variety of care delivery systems, the use of technology for decision support, and the availability and use of evidence-based clinical information. Community resource policies and availability to the family are also key in chronic care management. In order for decision support to be effective in chronic care management, evidence-based guidelines and algorithms must be embedded into daily clinical practice. Health education should be evidence-based and created using health literacy principles and must integrate expertise of both specialist and primary care providers. The concept of clinical value is demonstrated by the Clinical Value Compass. When considering the value of care, we must remember that value means improvement in the patient's clinical, functional, and risk of disease status, patient-family satisfaction in regard to the patient's needs, and in the context of reducing direct and indirect cost. That is, value equals quality divided by cost. Self-care is a critical component of both preventative health promotion and chronic disease management across the continuum of care. Patient self-management concepts can be addressed by the use of the 5A cycle, where the patient accesses the healthcare system, receives advice, agrees to a plan of care, asks for assistance, and utilizes arranged resources. The success of self-care is impacted by the patient's readiness to change behavior, their confidence in their ability to make the recommended changes, their ability to remove barriers that will prevent the patient from making changes to follow the patient-centered collaborative care plan. A critical part of the CNL role is to engage the patient in communication that fosters trust so that the patient identifies socioeconomic, personal, or other barriers to making needed change. The role of nursing in health promotion is to assist patients to identify their needs, guide them in creating a collaborative care plan, reinforce appropriate health behaviors, and to advocate for the patient and family who needs additional support and resources to be successful in self-care. There are several models that can assist the CNL in collaborative patient care planning. Orum's model addresses the self-care need, the adequacy of self-care in guiding care planning, and providing methods of helping the patient meet their goals. Orham's theory addresses care planning from the self-care patient perspective and the self-care behaviors that they need to achieve to improve their health. The health belief model addresses the individual's willingness to make health behavior changes. When a patient has demonstrated noncompliance with the care plan, the CNL can use this model to look beyond the behavior to underlying causes and then work with the patient to remove barriers to compliance. The model addresses the patient's personal beliefs about the seriousness of their condition and their susceptibility to disease. People are more likely to engage in health behaviors if they believe that they are at risk of disease. The key to using this model is the ability to understand the patient's perspective of the severity of the illness, their susceptibility to becoming ill, their perceived benefits of taking action compared to the cost of them taking the action, their personal motivation that will enable or prevent them from taking action. For example, when considering a plan of care to address type 2 diabetes that includes exercise and diet, the patient must see the benefits of changing their diet and increasing or starting an exercise program in contrast to their current lifestyle. Pender's model of health promotion approaches self-care based on the perceived benefits, barriers, and the patient's ability to self-care and to promote healthy behavior. It also includes the individual's past experiences. This model addresses behavior from a commitment to the plan of care, for motivators and barriers to change, and individual preferences that must be included to increase the likelihood of adherence to the care plan. Systems theory is important to CNL practice in improving health outcomes. The general concepts of the model are to collect data early in the care delivery process, review the data in light of past performance, and to create a delivery process where the staff do the right thing in the right way the first time for each patient that will come into the system. Symptom management is the guiding principle of palliative care. The patient's symptoms prompt the patient to seek health care and to be provided health education that is focused to help the patient understand the condition and how to self-manage their care. Issues that must be addressed are the patient's subjective perception of the impact of the symptoms on their quality of life and in choosing appropriate interventions to manage the symptoms. Integral to planning care is the inclusion of patient education. Benjamin Franklin said, "Tell me and I will forget. Teach me and I will remember. Involve me and I will learn." Patients learn 10% of what we read, 20% of what we hear, 30% of what we see, 50% of what we see and hear, and 80% of what we say and do. The adult learner, whether it is the patient or the parent, uses past experiences to build upon their learning. When beginning patient education, it is essential to understand what the patient knows about the condition and what they feel is important to learn, then to set mutual goals for the teaching experience. Health literacy is the degree to which individuals have the capacity to obtain, to process, and understand basic health information and services needed to make appropriate health decisions. Health literacy levels impact the ability to access and navigate in the healthcare system, to provide an accurate health or focused history, to engage in self-care management, and to understand their risk and probability for disease and cure. The impact on the patient includes understanding their options, their choices, and consequences of their action or no action, and in making decisions based upon the information and choosing the services that match their needs and their personal preferences. Healthcare professionals also require health literacy skills. They need to be able to aid patients in finding information and services, to clearly communicate health information to the patient and family, to understand what they are explicitly and implicitly requesting, and to make decisions on what to teach patients and which resources and services best meet the patient's needs. It is important when creating and presenting patient education to speak their language. Readability of health education material can be evaluated using the SMOG readability formula. The CDC also provides tips for creating patient education materials. Patient and family education must be presented in an effective way in order for patients to understand the instructions and to be compliant in following the care plan. The Ask Me 3 and Teach Back are two popular methods for giving consistent and effective patient education. Regardless of the method of teaching, it is essential to evaluate the patient's attention by looking for cues that they are not receptive to or understand the education being provided. Denying the need, changing the subject, paying poor attention, ignoring the information, asking are all signs that the patient is not attentive or not understanding the importance of learning this information. Patients who ask for information, pay attention, and actively participate tend to be more efficient in learning patient education and being able to apply it to their lives. Healthy People 2020 is another good source of patient education topics. Finally, remember that leading health indicators are focused on high quality care, longer lives, and the elimination of disparity and the creation of equity in health care.